I'm already on video. I'm on audio. Hi, everybody. Good morning. I'm Dr. Kathy Cook. I'm internal medicine attending. I'm on the transfusion committee, big transfusion champion. Everyone probably already knows this about me. Real excited to present it's kind of I think this is our third year for doing this, doing a transfusion panel. So we have 3 speakers today. We've got Dr. Syed, internal medicine, PGY3. We've got Dr. Garland in the PGY4 surgery. Dr. Puckett is PGY2 with ER. They're on the transfusion committee and very active and involved. We also have a panel with OBI, Dr. Stevenson, our famous pathologist, Dr. Soto's here. Shelley, our lab manager, is here. And again, they've been here every year. They're going to help answer questions at the end. So each speaker is going to do their presentations. We'll kind of, if there's something really breaking that you want to ask the speaker, you can after theirs, but I kind of want to just do a short 1 to 2 minute questions, but get into big questions at the end where everyone can participate. All right, let's get started. Go for it. Do we need to use the microphone? Heather, can you hear us okay? Should we use the microphone?
Yes, ma'am. I can hear you just fine, but I believe whenever we tested and you were using like the handheld mic, it was a lot clearer.
Let's do that. Especially if someone's soft-spoken.
Okay. Hi, my name is Farzeen Syed. I'm a PGY3 with the internal medicine program at OSU Medical Center in Tulsa. Today we'll be talking about transfusion practices. This may be a refresher for some of you, and for others, it'll be a good introduction. So we'll break up our presentation into 2 parts. We'll start off with the clinical practice guidelines of blood products, and then we'll talk about the American Association of Blood Banks Choosing Wisely campaign. So to start off with, pack red blood cells. To optimize blood transfusion decisions, healthcare professionals should often employ a restrictive threshold approach. To initially start, a single unit of PRBCs holds approximately about 300 to 350 milliliters of total volume. So it's important to understand that whenever you are transfusing a unit of blood, you're giving about 300 cc's of fluid. Pack red blood cell unit will have 250 milligrams of iron approximately and around 200 mils of RBCs. And then the definition for at least anemia will be less than 13 grams per deciliter in males, and then less than 13, and then less than 12 in females. So in regards to restrictive threshold approach for patients, we want to make sure for an asymptomatic patient and critically ill patients, the threshold is set for a goal of at least 7 for their hemoglobin. However, for patients with pre-existing cardiovascular disease or those that are undergoing orthopedic surgery, the threshold is slightly higher at 8. It's also important to note that a serial recheck of hemoglobin levels should be avoided in clinical stable patients to reduce unnecessary interventions. It's first important to determine the cause of the anemia. We want to view every single blood transfusion as a transplant due to the increased risk of potential reactions each time you do get a unit of blood. And then when possible, you need to go, well, one you should start off with is typing and screening. And this is going to be valid for 72 hours. The type and screen uses only the recipient's blood and determines what type it is and any antigens that are actually present. This will be your preliminary screen. The next step will be a type and cross. This test mixes a sample of the compatible donor's RBC unit for transfusion to the recipient sample. And this should be a type and cross should be done when you have a high clinical suspicion that a patient will require transfusion. This process will take about an hour's time, but in emergency situations, it can take up to 2 to 3 minutes. It's also important to use non-transfusion practices to help with perfusion. You want to ideally maintain hemodynamic support with fluid resuscitation as needed. You want to correct any underlying deficiencies. And don't transfuse if you know that someone has iron deficiency anemia. You can go ahead and try to replace their iron levels. This is somewhat of just a chart breakdown of what we discussed about the hemoglobin levels, less than 7, when to transfuse, 7 to 10, if they have those exceptions that we discussed, such as cardiovascular disease, orthopedic surgery, and so forth. And then now you have those numbers as a rule of thumb, but each patient is different and you want to look at that clinical picture. If someone even has a hemoglobin greater than 10, that's their baseline, but you know that they're actively bleeding, you want to use your clinical judgment and go ahead and transfuse. So this is a report generated by OBI. Cohort 47 is actually our institution. This graph shows all the regional hospitals similar in our size and how we compare. And luckily enough, for at least our first quarter in 2023, in comparison to last year's quarter, we've had a decrease in our red blood cell usage. And I think that's main thing is the transfusion committee really takes a commitment to go ahead and take the steps to educate and then also review any cases that we feel may potentially be inappropriate transfusions. This is just another indication of our BC usage to overall red cell usage. Again, we're cohort 47. And then we've also had just a further decrease in 7.2%. One of the main goals was to get our O negative usage below 12% from 2021 to 2022, and we are still meeting that goal actively in 2023. And then in regards to platelets, so who to transfuse? If you have a patient less than 10,000 platelets, you want to go ahead and transfuse specifically because they're at an increased risk for spontaneous bleed in afebrile patients. Less than 20,000 will be patients that are undergoing procedures that are not, I guess, major procedures such as bronchoscopy, central lines, lumbar punctures, bone marrows, and then patients that are febrile or septic. Less than 50,000 will be major surgeries, and then patients that are actively bleeding, and then less than 100,000 are people that are going to go for neurosurgical interventions and neurosurgery. And then when not to transfuse. Contraindications for platelet transfusions will mainly be TTP and also HIT as well, just because whenever these processes have a huge role with platelet consumption. So it would be a moot point to go ahead and transfuse platelets at that time. And so transfuse hospitalized patients, like I said, with platelets counts less than 10,000. The AAB recommends to reduce this to transfuse to reduce the risk of spontaneous bleeding. As a general rule of thumb, transfusing a standard pool of whole blood derived platelets or one apheresis unit should ideally increase your platelet count by 30,000. Following a platelet transfusion, the platelet count typically experiences an initial increase around 10 minutes to an hour, and then you'll have a slow, gradual decline in the next 72 hours. Platelets must be stored at room temperature, so this limiting the shelf life of platelet units to only about 5 days because of the risk of bacterial growth during storage. And then platelets are usually stored at room temperature because when they're stored in cold environments, this induces the clustering of the von Willebrand factor receptors and leads to enhanced clearance and reduced platelet survival in the recipient. So fresh frozen plasma. Plasma is a crucial component of blood, primarily known for its role in clotting and providing essential proteins. 1 unit of plasma will have about 200 to 300 fluids of frozen blood containing clotting factors and plasma proteins. Some of the components of plasma contains fibrinogen, albumin, protein C, S, antithrombin, and tissue factor pathway inhibitors. There's no red blood cells or white blood cells within plasma. A standard dose will be about 10 to 20 mils per kg. And then it'll be about 4 to 6 units will raise the factor levels by about 20 to 30%. Plasma needs to be used within 24 hours after thawing or within 5 days to maintain its effectiveness. In the past, FFP was often used for vitamin K for warfarin excess and life-threatening hemorrhages. However, we are slowly moving towards away from that. Nowadays, PCC or prothrombin complex concentrate is more commonly used for warfarin reversal. And so therefore moving, like I said, towards limiting the use of FFP. So indications for FFP use will be in cabbages, MTPs, ECMOs, DIC, liver cirrhosis, and then only in the emergency need for warfarin reversal with active bleeding. And then plasma transfusion, like I also said, is also indicated when there's a concomitant plasma volume deficit. Now, cryoprecipitate is a specialized blood component that can only be made from FFP. By definition, it has been frozen within 8 hours of the whole blood collection. Within cryoprecipitate, we find that we have fibrinogen, about 150 to 300 milligrams of fibrinogen, factor 8, factor 13, which is an essential factor for clot stabilization, and then von Willebrand factor as well. Each component of cryo comes in a volume of 10 to 20 mils, and its goal is to increase plasma fibrinogen levels to approximately 50 milligrams. And then cryoprecipitate is administered per 10 kilograms of body weight. For practical administration, cryo is often transfused in a pool of 10 units, and this practice will effectively increase the fibrinogen levels to 50 to 100. And then cryoprecipitate can also be stored and frozen for up to 1 year. It's essential to know that cryo is stored frozen and should be transfused within 6 hours of thawing or 4 hours of cooling. So this is just kind of reviewing what I said. 1 unit contains at least 150. The target level of fibrinogen levels at least 100 to 150. So you can see how we want to go ahead and use this in situations with DIC. Uremia refractory to DDAVP, where uremia does not respond to desmopressin, increasing your risk of bleeding. And then cryo is just valuable in cases of acquired hyperfibrinogenemia, resulting in conditions such as cardiac surgery, liver transplant, trauma, or hemorrhage. So this is our data from 2023. We can see that updates in the graph above, improvement in the usage of cryoprecipitate. However, there is a increased percent wastage of plasma use to about 2.4%. And this is actually just more of our discard report that we had in 2022. It shows that we've had an increased discard report of just plasma usage, and that's just a theme that we've had. But I know that plasma, like we said, we have a lot of cabbages that we have in this in our hospital, and then there's that specific need for it. So our next part will be the 5 things physicians should question prior to transfusing blood products by the Choosing Wisely campaign by the AABB. So let's start by discussing the first key consideration: avoid overtransfusion. It's crucial to minimize the risk associated with blood transfusions. To achieve this, we recommend adopting that restrictive threshold for hemoglobin levels, typically between 7 to 8. Thresholds can vary depending on the patient's condition. Always consider the patient's symptoms, hemoglobin levels before making our decision. Our goal is to start with a single unit of red cell transfusions and prescribe additional units only after reassessing the next patient and their hemoglobin level. And I think an important part with this is especially that whenever we are transfusing blood, it's important to appropriately document. That's going to also help the transfusion committee review just any transfusions that come up as a red alert when it says, oh, this was a transfusion greater than 7 or not. And then our next consideration, if this will work, is don't transfuse red blood cells for iron deficiency without hemodynamic instability. It's important to explore all. This is not coming up. 1 second. Oh, here. This is supposed to be a number 2, but our next consideration, like I said, revolves around not transfusing for people that have iron deficiency and that are hemodynamically stable. It's important to explore the alternatives to red blood cell transfusions when dealing with patients who have iron deficiency without any hemodynamic instability. Instead, we want to go ahead and opt for any oral iron or intravenous iron supplementation. It's also important to not also over iron load our patients. Going ahead and doing twice a day iron is not going to be optimally effective for these patients because your body can't absorb that amount of iron as well. And then this approach is also going to be cost effective and also safer for the patient, as we said, because each unit of blood transfusion should be considered as a transplant for a patient. Okay. Our next is don't routinely use blood products to reverse warfarin. So warfarin reversal. When it comes to patients requiring warfarin, we need to use alternatives that are both effective and safe. Vitamin K alone often suffices in many cases. And then you want to reserve PCC concentrates for situations involving serious bleed or emergency surgery. I will also say, at least for internal medicine boards, this is something that will come up quite often to know clinical guidelines. So when to do appropriate warfarin reversal based off of their INR and their clinical stability as well. So now I know that I also participate in this and I need to get better about this, but don't perform serial blood counts in clinically stable patients. We want to optimize transfusion decisions. So it's important to base them on the first laboratory value of the day for clinically stable patients. Repeated blood draws can lead to excessive phlebotomy and unnecessary transfusions. So we need to definitely be mindful about that. That also takes additional hospital resources. It's inconvenient for the patient. And like I said, it can also lead to unnecessary anemia for the patient. And if this will go. Okay. And then last but not least, and this was something that the Transfusion Committee has definitely taken a serious commitment towards improving. Don't transfuse O-negative blood except to O-negative patients and in emergencies for women of childbearing potential with unknown blood group. O-negative units are often in short supply, so we need to use them judiciously, especially following the COVID pandemic. We've had a limited supply of blood products, so we need to be very cautious about our O-negative usage. But however, we do have exceptions to the case, obviously, in very emergent situations, and then also women with childbearing potential with unknown blood groups. And then most importantly, especially with the overall shortage of blood products that we have, it's important to know where we can donate. OBI is a great institute to go ahead and call them to donate, especially platelets as well, not just PRBCs. And then there's also the Tulsa Red Cross Blood and Platelet Donation Center. All right, thank you so much.
Well, Dr. Garland's coming up. Also, I forgot to introduce Patty Barker back here with OBI, and she's got pens and pads for anybody who wants them, but I appreciate her being here. And we do have blood drives how often do we have them here?
I think it's every quarter.
Every quarter, so it can be convenient and easy for you guys to donate blood during that time too. Okay, go ahead, Dr. Garland.
All right, hi everybody. I'm Dr. Garland. I'm one of the PGY4 general surgery residents. So we're going to talk about massive transfusion protocol, the ins and outs of when to start it, how it started, and go from there. So to start, a quick overview, we're going to talk about damage control resuscitation, the ABC score to help with MTP decisions, proper trial, and then MTP protocol in general. And to follow that, our MTP workflow here. All right, so the current problem is that an estimated of 20 to 40% of deaths occurring in hospitalized trauma patients are secondary to coagulopathy, leading to continued bleeding and morbidity and mortality. So transfusion must be performed quickly in these patients and efficiently to reverse coagulopathy caused by trauma/hemorrhage. Significant pre-planning and coordination between blood bank, OR, ER, and delivery personnel should be in place to facilitate proper distribution of blood and product. MTP should be in place at any facility that has an urgent responding team. Okay, so to start, damage control resuscitation really started primarily in the early 2000s. So early 2000s, the goal of shock resuscitation was to give crystalloid to get blood pressure up, get urine output back up, and to hopefully reverse the metabolic derangements caused by ischemia associated blood loss. In 2007, Holcomb discussed more of the DCR or damage control resuscitation based off of the lethal triad, which is coagulopathy, acidosis, and hypothermia. And what the big discussion was that focusing on these along with that resuscitation and using less crystalloid would provide better outcomes for the patients. So DCR defined is a structured intervention beginning immediately after initial assessment in the ED through the OR ICU courses. Efforts are directed toward this goal by repeated POC testing and the use of multiple blood products / adjuncts readily available. In practice, the goal is really to keep systolic blood pressures above 90 as to not kind of break up any clots that you had previously, especially in like ruptured aortic aneurysms, things like that. And the other goal is intravascular restoration accomplished by using thawed plasma instead of crystalloid as volume to assist and to decrease the amount of coagulopathy that comes with high volume resuscitation via crystalloid. So one way to kind of further decide who's going to require MTP that was created in 2005, 2006, and has been adopted by the American College of Surgeons is the ABC score, or the Assessment of Blood Consumption score. As a retrospective cohort of all level 1 adult trauma patients transported directly from the scene in 2005 and 2006. The scores assigned based on the 4 non-weighted parameters, and this is the MD calc thing. So it's penetrating mechanism, systolic blood pressure less than or equal to 90, heart rate greater than or equal to 120 in the ED, and a positive fast. So if you meet 2 of those criteria alone, it's likely that you're going to need MTP. And so this has been used in multiple studies, including one that's helped us with guiding our resuscitations, which is the PROPER trial. So the PROPER trial, or the Pragmatic Randomized Optimal Platelet and Plasma Ratios trial, was a randomized 2-group phase 3 trial conducted in subjects requiring the highest level of trauma activation and predicted to receive MTP as defined by that ABC score, or when the physician saw the patient in the ED, they were like, this guy's going to need something more, okay, or woman. So the groups were separated in 1:1:1 ratios of packed red blood cells, plasma, and platelets versus the 1:1:2 ratios. This was done in 680 patients, and there were 2 primary endpoints discussed in this. So it was survival at 24 hours after initial trauma, and then 30 days after ED admission. The results really showed absolutely no difference in those 2, as long as you kept it as close as possible to whole blood resuscitation, which is that 1:1:1 versus 1:1:2. The only benefit noted from the 1:1:1 group, however, was that hemostasis was more quickly achieved, 1 in the OR and 2 in general in that first 24 hours, and less patients died of exsanguination on those first 24 hours. So this is why we kind of focus on that 1:1:1 ratio for massive transfusion. So moving forward, what is massive transfusion protocol? It's a process of management of blood transfusion requirements in major bleeding episodes, ensuring that appropriate use of blood products are used. It's designed to help decrease deleterious effects of trauma / hemorrhage, with the goal of reversing coagulopathy of trauma without wasting product, which Farzine kind of discussed at length. We are trying to limit the amount that we overuse. So it places an emphasis on controlling the bleeding, decreasing crystalloid administration, and administering blood in a ratio of balanced components, as discussed by that damage control resuscitation. So usually this is kind of composed, like most coolers are a 6x6x1 apheresis unit of platelets. I believe at OSU we have the 4:4:1 ratio. And it's vital that all involved services, including ER, transfusion, or blood bank, OR, everyone is involved in making this work well together as to not worsen patients' outcome. So development of a massive transfusion protocol at OSU, our transfusion committees meets every month to kind of work on this and discuss different cases. The massive transfusion protocol is a written document that's available to all of the staff to be able to identify who needs it and things like that. It has been developed by our multidisciplinary committee, and it's it addresses basically these following things. So the triggers for initiation of an MTP, resuscitation in the clinical setting, transfusion targets, use of adjuncts in patients with massive transfusion activation, and then how to terminate MTP once patient has been stabilized. So triggers for initiation of MTP. MTP is usually set into motion when massive blood transfusion is necessary, which is based off of the following criteria, but not limited to these. So one is need for 10 or more units of packed red blood cells within a 24-hour period. Transfusion of 4 units within a 1-hour period with anticipation for further need. Greater than 1,500 cc's blood loss documented at any time, massive GI hemorrhage, and then ruptured aortic aneurysms. Blood products at OSU, a whole goal, as we talked about for MTP, is to make sure that we utilize these blood products well, as to not overuse them or underuse them. So just to get an idea of how long these can be used and things like that. So packed red blood cells stored for maximum 6 weeks. And then the longer you use them, there is concern for increase of storage time leading to increased complications. Plasma should be stored thawed or liquid, so that's readily available for patients in the emergent setting, as taking or thawing or taking a frozen unit and then trying to thaw it takes a long time to get it up to the patient, and then leads to the not doing that 1-to-1-to-1 ratio. Then platelets, again, as Dr. Said said, not to be placed in coolers and should be stored enough, and that we do a 1-to-1-to-1 ratio, which I think has been an issue because of the amount of platelets available, I think has been a thing. So, and at completion of MTP, the remaining of the blood products should be returned to the blood bank. So that's something to keep in mind as well. So in the clinical setting, universally compatible blood products should be readily available upon arrival for the patient. So in the emergency department, in a fridge, they should have units available for the patient, and thawed or liquid plasma for the patients available. Patients should have baseline point of care labs drawn upon arrival, including a PTINR, fibrinogen, hemogram, ionized calcium, and ABG, to allow for correction of the factors contributing to coagulopathy like hypocalcemia, acidosis, and hypothermia. TEG and ROTEM can be used to direct therapy that tends to be after the initial initiation of MTP. For maximum effectiveness for MTP, you should utilize a rapid transfuser and warmer. Transfusion should restore perfusion, but allow for permissive hypotension, as we discussed, so that systolic of 90 until surgery or angioembolization can begin. And again, giving in that 1-to-1-to-1 ratio to decrease the risk of exsanguination in those patients. And then finally, transporting the patient. So in these clinical settings where we end up having to give patients MTP, we do tend to have to transfer the patients from ED to OR to ICU. And in all those settings, we have to make sure that the transfusion service or blood bank is aware of where we're going so we can send the blood to the correct place. Then endpoint to MTP. The decision to cease MTP should be made by the following. So it can be made by the surgeon/interventionalist after these 2 criteria are met. So the surgeon and interventionalist basically say, we've stopped the bleeding, and then you also see improvements in their heart rate, blood pressure, and urine output. It can also be stopped by the intensivist after this resuscitation initially, and then be guided along with POC labs to resuscitate them appropriately without overusing product. Some labs that can tell us that we can cease transfusion are also hemoglobin greater than 10, PT less than 18, PTT less than 35, platelet count of greater than 150,000, and a fibrinogen level of greater than 180. And then finally, which we've seen in futile efforts, MTP should be stopped. Some adjuncts to massive transfusion, TXA or tranexamic acid has recently become acceptable adjunct in massive transfusion based on its antifibrinolytic properties. TXA should be given in the emergent setting in a trauma patient or actively bleeding patient if within 3 hours of the injury. If not within those 3 hours or unknown time of injury, it's not shown to be of much benefit. Recombinant factor 7A has been studied in the setting of warfarin-induced anticoagulation, and it appears to decrease transfusion requirements, but there's still no long-term data discussing this. Then PCC has kind of already been discussed, that should be used for emergent reversal of warfarin in place of FFP. And it's currently being used in most traumas in Europe. And then some pediatric considerations, which we don't tend to get much of, but something to keep in mind. So it's the same ratio and concepts, but decreased volume. So that way we prevent circulatory overload. So 1 unit of packed red blood cells, 1 unit of FFP, and 45 cc's of platelets. And then in all kiddos less than 20 kilograms, they shouldn't receive blood through a rapid transfusion, but you should just use an inline warmer. So something to monitor our performance for MTP. It can lead to complications. As we discussed, it is a transplant. So something that we have to keep in mind. So we make sure we kind of look through these outcomes for patients. So non-hemolytic reactions, allergic reactions, respiratory complications, hemolytic reactions, transmission of disease, and death associated with MTP. And then important performance indicators for MTP to allow us to continue to improve is time to calling MTP to infusion of the first unit. So how long it takes us to initiate it when the patient gets here, and how long it takes for them to get that first unit is a big deal. Time for calling MTP to infusion of the first unit of plasma, and then ratio adherence, whether we were able to stick to that 1:1:1 ratio and see if that's a better outcome for those patients. And then informing the transfusion service of MTP termination within 1 hour of termination, which sometimes doesn't end up happening. Somebody says we're stopping MTP, but blood bank's not called, or nobody's been aware, orders aren't put in for that. So something to keep in mind when you're ordering this, and then wastage rates that we've gone over. So this is a basic overview of the MTP process, and I'll go over the new sheet that Dr. Cook sent me in a moment. But basically, physician orders MTP versus just emergent blood in the ER able to be used, and then go from there. Orders are placed in Epic. Someone's designated to be a caller to the blood bank. Somebody's a runner. Somebody gets the rapid transfuser, which we'll discuss about kind of all that afterwards. One nurse is designated to infuse blood products. One's designated to double check those blood products. Labs are ordered and drawn. And then the physician, after hemostasis is achieved or once stable, discontinues MTP, and somebody calls lab to discuss that it has ended. For residents, this is something to keep in mind that I know I've even been bad about using, and I'm on the transfusion committee, is the massive transfusion protocol summary. So this basically allows us to see what reasoning you had behind calling an MTP, when it was started, when it was stopped, and those should all be documented. So this should be pretty easy to fill out, but it gives us a better idea of what we can do better in the future for our MTP protocols. And then this is our new form for MTP. And I don't know if Dr. Cook wants to discuss this a little bit more, or.
Just for a minute,
Yeah, perfect.
I just want to let you guys know that we have we do have a MTP group, and we're actually meeting this afternoon. We're going to update our protocol, but it's really, it's nurse driven as far as the different roles that everyone plays in the room, but the physician does have the role of calling the MTP, obviously, and stopping it. But just to kind of keep this in mind is there are going to be designated nurses in the room, or even techs with, a different job. The communicator is going to actually be split into a documenter and a communicator. The sooner an order gets put in Epic, the faster it is for blood bank to prepare products. So if the documenter that's now we're going to have a role as a documenter. So if you can give a verbal order to put in the MTP to the documenter, then that can already set stuff in motion down in blood bank, and it can make things go a lot smoother as far as getting blood faster from blood bank. But just kind of wanted y'all to, I passed this out, but we are going to be updating it, but we have the rapid transfuser. But just so you guys know, when an MTP gets called overhead, the people that are responding, this is more nursing than actually a rapid response. Residents don't necessarily have to respond to this unless it's your patient. Same with surgeries, things like that. But basically who's going is people from the ER will go to the ICU or maternal child health. ICU will go to maternal child health in the ER when it's called. When it's called in the ICU, ER will show up. So both of the rapid transfusers will be present and making sure that there's no extra support that's needed. The other thing we kind of discovered, because we've been meeting, we've had a lot of recent MTPs, is the primary nurse taking care of the patient really can't be one of those roles. And at first we did have them as one of those roles. So we're kind of adjusting those things, but I thought this Grand Rounds is a great opportunity to just talk about it and see, does anybody have any questions about the MTP, what we're doing here at OSU while I'm up here? Or even online. Okay. Thanks, Dr. Garland. But I just wanted to kind of bring that up with you guys and kind of make y'all aware.
Well, that's basically all I had. So in summary, MTP can decrease mortality. Documented, easily accessible MTP is available for us to look at. So that's something as interns, as med students, as anything, because you guys are helping a lot on the floor. Make sure that you're aware of kind of how it works, and make sure to de-escalate from your MTP to allow for or disallow for overuse of products when not needed. So that's all I have. Thanks, guys.
Good morning. I'm Madison Puckett. I'm a second year EM resident, and I'm going to be presenting on the appropriate use of uncross matched blood. So some objectives from today's lecture are going to include what is cross-matched versus uncross-matched blood, the types of uncross-matched blood, any risks that are associated with using it, when should we use it, are we giving negative or positive blood, and how to use uncross-matched blood. So some basic definitions and how uncross-matched blood and cross-matched blood are obtained. You often hear the term type and screen. So what does that really mean? The type, or the ABO-RH testing, is the patient's blood cells are mixed with serum that is known to have antibodies against A and B to determine their blood type. So the patient's blood cells are also treated with anti-D antibodies to determine their RH status during this type. And then the antibody screen, also known as the screen, is used to detect the presence of the most common antibodies in the patient's serum. And so essentially the patient's serum is mixed with red blood cells of known antigenic composition. And then the cross-matching takes place, which takes the patient's blood that has been typed and screened from above. So say they're AB positive, and they mix it with a compatible blood donor. So a bag of PRBCs that are AB positive. If agglutination occurs during that, then it'll allow you to know that there are some unknown antigens on the patient's red blood cells that are reacting badly with the donor's blood, which was not identified during the initial screen. So as such, even though the type and screen was done, you wouldn't transfuse that unit because the cross matching has failed. So for uncross-matched blood, you can use the patient-specific blood type if you know what that is at the time. However, O negative or O positive is usually used. That's depending on the patient's age and gender, which we will talk about later. But O negative and O positive are usually used because uncross match is usually ordered before we're able to obtain any labs on the patient because it's an emergent situation. So uncross matched blood can usually be dispensed within about 10 minutes, and cross matching at OSU takes around 45 minutes. So uncross matched blood, when used, is usually used when there's no time to wait on a type and antibody screen, which is what we just were talking about. So this is in a patient, for example, someone with a gunshot wound who's tachycardic, hypotensive, confused. This isn't to be used in someone who's asymptomatic with normal vital signs or appears otherwise clinically stable. Uncross matched blood isn't the same as massive transfusion protocol like Dr. Garland just talked about. MTP is used for an acute hemorrhage in which large amounts of those blood products are needed, but uncross matched blood uncross matched blood is usually used during MTP until you are able to obtain the type and screen. And then that blood would be switched to cross matched blood products. And uncross matched blood is needed when you need blood fast, not necessarily if you need them in large quantities. There are risks associated with transfusing uncross matched blood. As uncrossed matched blood does tend to be type O, or the ABO identical to the recipient. If you've had time to perform the cross match before, there is usually no risk of any immediate intravascular hemolytic reaction that might occur due to ABO incompatibility. However, there is the potential risk of less severe types of hemolytic reactions occurring if the recipient has unexpected antibodies that target other erythrocyte antigens such as D, E, KEL, Duffy, found in an uncrossed match unit. So extravascular hemolysis is something that can occur. It's rarely life-threatening, but they can shorten the half-life. They can shorten the circulation lifespan of the transfused RBCs, therefore reducing the effectiveness of that transfusion. There was a meta-analysis performed in 2015 looking at around 10,000 uncrossed match units, which found that there was only about a 0.1% risk of hemolysis with uncrossed match transfusions. And most people who develop any allo antibodies are asymptomatic. And then additionally, which we'll talk more about, but especially in cases of O positive blood given to an Rh negative female of childbearing age, it is important to consider that she's now been sensitized with anti-Ro antibodies and will require a RhoGAM for future pregnancies. So are we giving O negative or O positive blood during these situations? So it depends. In all males and any women greater than 50 years of age, you want to use O positive blood just because there is a limited amount of O negative blood. If an Rh negative female of childbearing age does have to receive an Rh positive transfusion during her resuscitation, so if the hospital ran out of O negative blood or there was a misidentification of the patient, then there is a risk that they could become alloimmunized to the Rh antigen, which could lead to hemolytic disease of the fetus or newborn if she subsequently becomes pregnant and her fetus is Rh positive. So RhoGAM can be administered in this scenario, as it has been shown to be effective in preventing Rh alloimmunization. If an Rh negative female receives more than about 2 units, it's recommended to perform an erythrocyte exchange transfusion to remove as much of the incompatible Rh positive erythrocytes as possible. So there is a limited supply of this O positive and O negative blood. So you want to order uncrossed match blood as we discussed previously. Once the type has been performed, you want to switch from the O blood to their type specific blood. Once cross-match antigen studies have been performed, then you want to completely switch to their cross-match blood. It's safer for the patient. And treat potential alloimmunization as necessary, like we previously discussed. The blood bank should have protocols set, but make sure that O negative blood is saved for these young females and O positive blood is used for the remainder of the population. And these are references, and that's all.
All right, guys, we're going to open it up for questions. And you can ask questions of the speakers or our panelist guest here. So if anybody has a question. About it.
In our hospital, how many of our nursing staff are all trained in MTP? I mean, are all the ER nurses trained? Do we have floor nurses that are trained specifically?
So everyone, they did MTP drills, and all the nurses went through those MTP drills when we first originally started doing this. Now, presently, there may be new hires, things like that. And now that we're making changes to the MTP protocol, we will be re-educating all the charge nurses, nurse managers, house supervisors, some certain staff that we may not be able to get all nurses through that training, but we will make sure that the people that are in charge will be trained. And it's a good question. Anything? Any other questions? I mean, we have our wonderful panelists here. So please feel free to ask any kind of question about blood products, transfusion.
I actually have a question for blood bank. Whenever we have an uncross match order and we want O positive blood, is that something that just automatically is given to patients that are male and 50+ for females, or how does that work?
We reserve the RH negatives for women of childbearing age and then adolescents.
Any other questions? How about any questions on Zoom? Heather, were there any questions on Zoom?
Yes, we did have one question from Philip Ridgway. Sorry if I mispronounced your last name. To clarify from the first presentation, should hemodynamically stable patients whose HGB is less than 7, do they need transfusion or simply iron supplementation? And I might have butchered that question as a whole.
No, it's a good question. So basically what the question is if a hemoglobin is less than 7, but the patient's hemodynamically stable, do we need to give blood products or should we be given iron? And this would be a great example of a woman who, let's say, has heavy menstrual periods and she has been living with a hemoglobin of 6.5 for a while. She comes in and her heart rate's not 100 greater than 120. Her blood pressure is fine. Should we be giving her, should we react to that number and give her a unit of blood?
You don't need to. So these people, like Dr. Cook said, they're physiologically compensated for living under those anemic phases. If you give them blood, the risks supersede the benefits of just giving them iron. And if you give them enough iron over the course of several weeks, they'll be able to come right back up. But that happens very frequently. That's a great question. We have seen that a few times in our committee. The field to need to treat numbers instead of actually looking at your patient and evaluating them clinically. So if you see that number, of course, do a very good clinical assessment for any other things that may be causing it. Rule out hemorrhage, not just menses. And then if everything is she's stable and everything else in an outpatient setting, you don't need to give her blood. And that goes for other things like, if you have a patient with hemorrhoids, they can become severely anemic. And then look at other things like, do they need to get banded or anything like that? Because giving them blood, they're going to come back in a month and be back where they started.
Any other questions? Go ahead. Just speak loudly and then I'll keep.
I was just curious because I know when we give people blood, we don't necessarily need to do any iron studies on them because that could be incorrect, right? Does that apply to a reticulocyte count? Is there a time frame that we shouldn't be using a reticulocyte count after transfusion?
So it depends. You're saying like, your iron studies can be false positive or false negative, something like that. Yes, I mean, your ferritin, that's why we do an iron panel, because your ferritin is an acute phase reactant that can go up and down depending on how the patient is. And same with your TIBC and things like that. But even retic counts can give you a false positive. So, you have to look at all together. If you have a patient who is cirrhotic, in an acute inflammatory stage, septic, their reticulocyte count may not be very high, even though they're in active hemolysis or bleeding or something like that, because their bone marrow is just not responding. Patients with chronic kidney disease, their reticulocyte count is just not going to be appropriate for the level of anemia. So look at it all together. So if you have a patient who, I don't know, what clinical scenario you're thinking of, we can kind of talk through it.
Like if somebody comes in with acute anemia and I want to make sure that their bone marrow is responding, I guess, should I wait 72 hours to check a reticulocyte count? Like, is that influenced heavily by just getting blood?
Retic counts don't fluctuate that much.
Should be pretty accurate then if we.
I think the retic count is has a very good positive predictive value. So if you see it high, it tells you a lot more than if you see it normal or low. You know what I'm saying? So if you have a patient you've been monitoring for a while and reticulocyte's low, and there's not really another reason for it, I would start looking for something like a primary hematopoietic disorder, like MDS or something in the bone marrow that's going wrong. But if you see your patient's acutely anemic and the reticulocyte count is high, that can tell me a lot more. Then you start thinking hemorrhage, hemolysis, things like that. But its negative predictive value is kind of non-specific, doesn't tell you a whole lot.
All right. If a rapid here's a question on if a rapid transfusion is needed but not available, what are the options to administer product? A rapid transfuser will be available. We have 2 in the ER, and there's 2 in the OR and I think 1 in the ICU. So they should, that's why we have an MTP we call overhead, the rapid transfuser. But saying that question brings up a good point. Access is what's gonna limit whether you can use the rapid transfuser. You need it to, an 18 gauge or a cordis. If you put a quad lumen in, you're not gonna be able, think about, right, small diameter, long, you're not gonna be able to pump in as much blood. That's why the cabbage patients always get a cordis, is so you can dump in a lot of blood quickly, right? Short, big diameter, whatever physics all that is. I can't remember that. If a transfusion reaction occurs, how long after treatment is given can products be administered to the patients?
Repeat that one again?
So if a transfusion reaction occurs, how
Oh.
long after treatment is given can the product be administered to the patient? I guess like you're given a unit of blood, I'm assuming, you're given a unit of blood, they have a reaction. When can we restart and do we give another unit of blood and when can we do that?
We can both answer that one. Okay, transfusion reactions. So in my case, it's again variable, depends on what the transfusion reaction is. Most of the time it's an allergic transfusion reaction. They start getting some rashes, hives, itchiness, things like that. Give Benadryl in the next unit and it's totally fine. Then, if you give blood and they start getting chest pain, chills, and our DAT is positive, it was a hemolytic transfusion reaction, we're gonna have to do some workup and maybe a little while until you get appropriate blood for that patient. And then you have to do, kidney protective measures to make sure kidneys don't get damaged. But most of the time, we rule out the worst things and then shortly after you can get blood again. But they call us first and then we have to give the okay.
Yeah, I agree with that statement, but it's very important for the hospital bed bank to kind of take a look into it to see what likely is going on. Is it an allergic reaction, febrile non-hemolytic, or is there actually some hemolysis going on to be able to best direct ongoing transfusion support and assist the team and evaluating what the next steps might be to care for someone who has a significant transfusion reaction. But typically, folks can move forward with transfusion support, especially if they still need blood products. But we need to do it in a safe manner.
Are there transfusion recommendations for patients with sickle cell disease?
They'd exchange transfusions. So just giving them more blood doesn't really help them. They're going to get iron overloaded from how many times they have to get transfusions. So we have to give them exchange transfusions a lot of times, especially in the acute sickle cell crisis patients.
Yeah, the sickle cell disease population is a population that oftentimes needs ongoing transfusion support, and some need to be transfused, fairly often using a red cell exchange automated treatments, and kind of varies from patient to patient, but the support of these patients can be a little bit tricky because they tend to have a kind of a pro-inflammatory state, and so they tend to develop multiple red cell antibodies, and so if they do develop a number of red cell antibodies, then it becomes a little bit more difficult to find, compatible blood for those patients. But even if they don't develop a range of red cell antibodies, there's still some basic requirements, and you probably follow it here too, that there are certain things that one matches for, and that's C, E, and K. Then of course try to give type-specific ABO, type-specific red cells as well. But in this patient population, if we're trying to match C, E, and K, you really more lean into Rh negatives because those are the best folks to match for those requirements, especially the C and the E. And so there's fewer O-pos donors out there that meet those requirements, but we're always looking for more patients that are O-pos so that we don't need to lean as much into the O-negs to support the sickle cell disease population. And so they're challenging, but they could be supported. And I would say one thing about the red cell exchanges, we have people that come in to various hospitals that get exchanged maybe every 4 weeks or so, and it may take between 6 to 12 units per exchange, just depending on how big they are. And so they do use a number of red cell units. So we continually try to recruit and even find some good donors for particular patients to best support them. So, but there can be a tricky population to support, but we do a pretty good job.
I thought I saw some other hands. Any other questions in here? How about on, go ahead.
Could you just let us know what resources OBI has, or like what services you guys can offer, for example, with like patients that have polycythemia vera and so forth like that?
One of the things that we do offer for patients that have conditions like polycythemia vera, where they overproduce red cells, is we actually provide at an outpatient basis free to them phlebotomies. And so we do have a therapeutic phlebotomy service that we provide. And so somebody with, say, polycythemia vera, maybe they have terrible COPD and their hemoglobin's too high, or more commonly these days, people that are taking testosterone, and we all hear those advertisements on TV and this, that, and the other. So we do have a number of people that on testosterone that need to be phlebotomized, because one of the things that testosterone does is it causes your bone marrow to overproduce red cells. And but those individuals can contact OBI, and we can schedule them to come into one of our centers, and we could phlebotomize them. And that's a free service to them to knock down their hemoglobin level. And they can come in, say every 2 weeks up to, every 8 weeks, depending on their need. And also people that, can't serve as just regular blood donors because they have something that would defer them, maybe the hepatitis, hep C, that sort of thing. But if they need to be drawn, they could also be drawn as a therapeutic phlebotomy patient.
Any other questions on Zoom or in the room? If not, just one other comment that there is lab panels that if you're worried about a reaction to blood products, there is there is an actual panel that we order to make sure to check everything that we need to. It goes to Dr. Soto to look at, or whoever the pathologist happens to be. Do you guys have any other comments? How about from blood bank or? Yakimi, do you have any comments?
No, I think you hit everything.
Okay.
Presentation was really great.
Yeah.
It's a lot of information to go over in 1 hour.
Yeah, very good information. And I'll say, thank you for having me here this morning. It's great to have OSU as a partner. OBI is your blood supplier. We supply all your blood needs. And so, come out, donate with us, come to one of our drives here, because if you donate with OBI, you are supporting your own, blood supply. And so we appreciate everything that you do, and your blood stewardship and management, decreased overall usage. And I think your ONEG usage is also improved, which is really great, because there's only, about 7% of the population is ONEG. And so they're, a high priority for us to have come in to donate, and then also for y'all on the hospital end to really use those resources appropriately, and to support the blood supply in general, and the ONEGs and the ANEGs, the BNEGs, and all that. So thank you very much. I really do appreciate it.
2 things I want to say. My PSA is, if you give blood products to your patients and they start having difficulty breathing, dyspnea, hypoxemia, think of TACO. It's always an underreported, historically, transfusion reaction. And we haven't had one in a while. And I always wonder why, because we should be having, it's just by numbers, we should be having some. So if you notice that, think about TACO, and those patients need to be diuresed. And second, I hope these presentations motivated some of you guys to join Transfusion Committee. Some of these results are the direct effect of Dr. Cook and the residents like you joining and being more educated on how blood products work and transfusions and all things like that. So I'd welcome you guys to join and get involved with that. That's it.
Oh, we got a question?
No, the code.
The code's 1972. Thank you. I forgot to say at the beginning, but and then it's been put on there. Okay. Thank you guys. Thank y'all for.
You're disappointing us.
No, I might.
I can be, like, you can let them know, like, I'm done. Out of here now.
Can we schedule a date?
Like
7 o'clock my
yesterday.
Taylor, Kevin, and,
Just come get it.
A little wine. Oh, yeah.
Forget about that.